So this week was a really popular eyes and ears week for whatever reason. I think that a lot of the students in the area are in orthoneuro, and that's what I've been tutoring on this week. So I wanted to do just a little quick tutorial, and it's going to kind of cover what I did with the students as far as common eye disorders. So this is going to be just a short and sweet review. One of my biggest things is that I think it's most important that you understand concepts. Understanding concepts as a whole is what's really going to help you out. So when I say that, I mean, don't get caught up in trying to memorize and remember every single little finite detail of a disorder or an illness, because I know how overwhelming nursing school is and how tough it can be to study and to try to read everything and listen and lecture and figure out what to know and what not to know. But if you can master a concept, so you have the general foundation of the issue, then your ability to apply that knowledge to different scenarios like NCLEX style questions, and maybe to just, more lecture talk and getting deeper into the issue, it's going to come easier that way. So try to focus on that. So this is really going to be like a broad concept about different eye disorders. So what you're looking at here is an image of the eye. It is, if we could slice the eye in half, and we'd be looking at it from the side. So what you see here is, if my pen would stop drawing all over the place, you can see that we have the eye, we have our cornea that's kind of popping out here, our iris in green. So here's our iris in green. And so this person would have green eyes, right? And then behind that we have our lens. And I kind of just colored it in blue. I don't know why, because I just think that lenses are blue. That's just how my mind works. And then the rest of the eye. So we know the back of the eye, it's filled with this aqueous humor. And then we know the very back of the eye, we have our retina, which I'll draw in later to show a different disorder. So the first thing let's talk about is glaucoma. Glaucoma was a big thing that came up. So glaucoma can either be open angle or it can be closed. And sometimes you'll see it as narrow. So it'll be written as open or closed or narrow angle. So the issue with glaucoma is increased pressure. We know it's increased pressure in the eye, just like you can have increased pressure in the brain, right? In the cranial cavity, like intracranial pressure can be increased. You can have increased intraocular pressure. And so how does that happen? Well, short and sweet, right? We have fluid in the eye. We know that. Our eye is filled with fluid and our eyes are lubricated all the time. That's why our eyes are wet. Well, in glaucoma, there's two different issues. This is going to represent my open at the top. And then at the bottom will be the closed or the narrow angle. So I'll put that there, or narrow. So what happens in glaucoma and our open, let's talk about that. The fluid is coming from the back of the eye, right? Comes in front of our lens, goes around our iris, and it empties out through these ducts, which are these little yellow things here. Now, normally what should happen is this fluid flow should be continuous, it should be easy. In glaucoma, in our open angle glaucoma, it's following the same path, except these ducts become clogged, and so this fluid starts to back up. And so it should be emptying, but instead it starts to pool a little bit. So let me just show like it's pooling. So it starts to pool a little bit, and then it'll pool a little bit more, and it'll pool a little bit more. And so what you end up with is this buildup of fluid at the front of the eye, right? That's pushing essentially both ways. It's going to be, let me get my pencil here. The pressure is going to build up here in this open angle. It's open angle because there's access to the duct and there's an open angle between the cornea and the iris there. So this pressure is going to build up, and it's going to start to push back. It's going to force pressure against the eye. And that's not a good thing, because that can actually cause damage to the optic nerve if you have too much pressure pushing back on the optic nerve. And so that's our open angle. That's a short and sweet. That's how that happens, and that's why it's a problem. It's going to increase all this fluid accumulation in the front of the eye. That's going to essentially push back, because just like our brain and our skull, we only have a certain amount of space in our eyeball, right? So if it starts to push back, then we can end up with a pressure problem. Now in the closed, My pen is scribbling all over the screen, as you can see. I'm trying to fix that. In our closed angle, what happens here is the same idea, right? We have fluid coming from the back of the eye that should be coming towards the front and draining out the ducts. But what do you see? Our iris and our cornea, so here's our cornea, right? And here's our iris. So here's the angle with our cornea and our iris. It's closed. We can't get to that duct. So instead, the fluid is rerouted right back into the back of the eye. And that's a problem. It can't even get through. And you also notice that we have this angle of the iris that sits flat against the lens. So there's no escaping out of there. But more importantly, we have this angle that's closed against the duct, so there's no escaping. Now, one of these is worse than the other. So just think about it for a second. Which one do you think is worse than the other? Meaning, which one do you think is going to create a problem faster than the other? So take a minute to think about that. Now, if you said closed, you'd be right. And the reason is that even in open angle glaucoma, though the fluid production is still happening at its normal rate or an increased rate, it's draining even though it's draining slow. So we're still able to put off some of that fluid. But in the closed angle glaucoma, that fluid is not going anywhere. It can't even get out through the ducts. So this is going to increase the pressure very fast. If that happens and it's not treated, it can lead to blindness and just general loss of eyesight, loss of eye function. And once eye function is lost, eyesight is lost, I should say, there's no restoring that. So it's an emergency. Now, our common symptoms, and this is always important for NCLEX testing purposes, halo vision. And the reason why this happens is that this halo vision is that in somebody that has glaucoma and this increased intraocular pressure, they lose peripheral vision. So we call that halo vision. So they lose peripheral vision. So it means they can't see things that are off to the side. And that halo vision just means that things that are more towards the center of their line of vision, they can see clearly, but not things off to the side. So when you see halo vision, you should be thinking about glaucoma. Some of the signs and symptoms you'll see in glaucoma: you might see nausea, you'll see redness in the eyes, and they might be complaining about blurry vision. If somebody has those complaints, it's important that we recommend that they go see their eye doctor right away. If their eye doctor is not available, they need to go see an ER physician or go be seen quickly, because we know that those signs are associated with close angle glaucoma, and those are early signs, and we want to prevent any loss of vision as much as possible. So if they're complaining about those things, you want to make sure that you recommend they get seen. So here's glaucoma. So we have our open angle, our closed angle. We know the issue is increased pressure because of the fluid load. Either it's not being drained out quick enough, or it's just not being drained out at all. And the big sign, halo vision, halo vision. So when you see those on your test, you know halo vision is with glaucoma. They don't have peripheral vision, okay? So then in our next one, let's say is cataracts. So cataracts essentially is an issue with the lens. So it's an issue with this guy right here. Now our lens is made up of water and protein. And as we get older, that protein starts to clump together a little bit. Now when that happens, let me change a color here. Okay, so when that happens, when we start to have that clumping of protein in our lens becomes cloudy. Clumps of protein is going to cause it to be cloudy. So I changed it to this kind of yellowy color so you can see that. So how do you think the person's going to see? Well, in cataracts with a cloudy lens, their vision is going to be very blurry. So they're going to have blurry vision in cataracts. So blurry vision. I'll write that right there so you can see that. And that's the issue. And so why does that happen? Well, we know that light comes through the front of our eye, right? And it goes through our lens and it bounces off our retina, and then we're able to, make an image. It goes through our optic nerve to our brain. We make an image. Long story short, what I want you to know is that cataracts is this blurry vision because that protein's starting to clump in our lens. And this can be, age-related, meaning that's very common the older that we get. So again, imagine if you wear glasses and say that somebody smudged your glasses with dirt. you might be able to see out of it, but you're going to see really blurry. And so that's what happens in cataracts. Now, of course, the biggest complaint, that sign and symptom you're going to see is going to be blurry vision. That's what they're going to complain about early on. Our treatment, of course, is going to be geared towards the lens. So ideally, our end resort is going to be to remove the lens, take out this cloudy lens and replace it with the synthetic one that's clear so the person can see. Now remember, in nursing, we always start with the least invasive, right? The least invasive procedure, of course, if it's not life-threatening, to the most invasive or an invasive procedure. So early on, we'll try to give this person corrective lenses to help them with their vision. And then if that's not working and this cataract is becoming progressively worse, then we're going to have to do surgery for that. So that's a big thing with cataracts. So in testing purposes, when it asks you for symptoms, we know we're talking about blurry vision. Now, if we do another one, let's say we do macular degeneration. So in the back of the eye, in macular degeneration, we have something called a macula, and it kind of sits toward the center of the retina. Now, what the macula does is it helps us to have focus in central vision. So think about what would happen. If this is damaged, then we're going to lose the ability to have focus in our central vision, but which doesn't affect our peripheral vision. So just like in glaucoma, we couldn't see peripherally, in macular degeneration, you can see peripherally, but you have a hard time focusing on central vision. So that means like reading, seeing people's faces, road signs, if you were like knitting, for instance. So things that are in your direct central line of vision, you lose the ability to see that. Now, this is again something that's age-related, damage to the macula. Some of the treatments are more geared to actual like vitamin and antioxidant therapy to try to save the vision. And of course, thinking about least invasive to most invasive, the end result of trying to treat this would be surgery. So for the symptoms for macular degeneration, loss, and I'll just put this no sign, of central vision. So remember that. We have cataracts, blurry vision, right? Glaucoma, loss of peripheral vision, which is our halo vision. In macular degeneration, we're talking about loss of central vision. So when you see those in question scenarios, think about what that loss of central vision would mean. And then finally, let's do retinal detachment. So we know that our retina is at the back of our eye, right? So I'm kind of drawing this a little bit poorly. But let me fill this in here. Fill that in. So let's say this whole back portion is our retina that I colored in red, right? Well, in retinal detachment, what happens is that this retina, let me actually change the color here. I can actually make it this. Okay, so the retina becomes detached from the back wall. So let's say that here at this point, you see that it's detached from that area. Well, we know that our retina is what sends these light signals through to our optic nerve, to our brain, and that's how we're able to develop an image. That's how we get an image. Light comes in, let's put this, light comes in through our eye, through our lens, right? Bounces off our retina sends a signal through our optic nerve to our brain, and here's my brain, and we're able to see what the image was at the other end. That's how we have vision. So with retinal detachment, obviously we know that we're going to have a visual issue. The big thing with retinal detachment that you must remember, because again, this is going to help you in testing purposes, is it's no pain. There's no pain related to this detachment. However, the early signs that someone's going to complain about is floaters in their eyes. So they might be seeing like specks or white things or strands and squiggly line looking objects floating around in their eye. Light flashes, they might see flashes of light, and a curtain effect. So kind of like a blackout, like a curtain. Now, with retinal detachment, the goal is to reattach the retina back to the eye. So that can be done with surgery, and that can also be done with this procedure that they do that has a gas bubble. And essentially, they will inject this gas bubble into the eye, and here's just a poorly drawn bubble. And position the patient prone, so face down, and thinking about gravity and air and how that movement would happen, the gas bubble would rise to the back of the eye, and it would push the retina back against the back of the wall, and it would reattach itself there. So the goal in retinal detachment as far as treatment and therapy is to reattach the retina to the back of the eye. What you should remember in retinal detachment are these things here. So these first initial early symptoms: floaters, flashes in the eye, that curtain effect, and no pain. It is not related to pain. So that's the quick and easy of the eyes, so you can remember. So let's just look at this quick. So cataracts, think blurry vision, right? We have that cloudy, dirty lens. In our macular degeneration, we lose the central vision. And in our, what else did we have? We had in our glaucoma, we have that halo vision, and that means that we lost our peripheral vision. And then our retinal detachment, think about those floaters and those flashes, but most importantly, it's not a painful event, okay? A decrease in aqueous, oh Lord, my stuff's writing all over here. A decrease in aqueous humor production and a decrease in the outflow of aqueous humor. A decrease in aqueous humor production and an increase in the outflow of aqueous humor. A decrease in aqueous humor production or an increase in aqueous humor production. And don't mind my pen writing all over the place because clearly it's on the fritz. So again, trick, always read the question twice and pull out the information. So we know that this person is taking Propine, right? They're taking it for glaucoma. The question is, how does the nurse explain how this medication lowers intraocular pressure? So it lowers intraocular pressure through which action? So we should be thinking about glaucoma. Again, ignore my pen. Thinking about glaucoma, thinking about what the issue is. We know it's intraocular pressure because we have this increase of fluid that's happening and it can't get out because the ducts are clogged, or if it's the opposite issue where it just can't get out at all, the ducts. So this is the information that you're thinking about right now. This is the stuff that's going through your brain. We know that's what glaucoma is. So what makes the most sense? A decrease in aqueous humor production and a decrease in the outflow of aqueous humor. Well, a decrease in the aqueous humor production would help so we don't have such a buildup of that fluid, but do we want to decrease the outflow? No, we want the outflow to be increased, right? Because we want to get rid of it. So that can't be it. A decrease in aqueous humor production and an increase in the outflow of aqueous humor. So we want to decrease the amount of fluid that is being created, and we want to speed up how fast it's being put out. Well, that sounds good. So I'll put a check next to that. A decrease in aqueous humor production. Well, do you want to decrease the fluid production alone? Is that going to be enough to help the pressure in the eye? We're not really doing anything to get rid of it at that point, right? So I don't like that one. And an increase in aqueous humor production. Well, we know that's a problem. We don't want to add more fluid into our eye, right? Because that's going to add more pressure. So we got to get rid of that. So the only one that makes sense here would be B. A decrease in the aqueous humor production and an increase in the outflow. Now this one here, which would be the best approach for the nurse to use to verify understanding of instructions about how to take oral Nystatin given to an older adult client with presbycusis? So what do you have to know for this question? And this was probably the more confusing one that I did with the students today. The question is asking the best approach for the nurse to use to verify understanding of instructions about how to take the oral Nystatin given to an older adult client with presbycusis. You must know this term in order to help you answer the question, right? Presbycusis, we know, is just hard of hearing, so we know it's a hearing issue. That is a terrible writing. Well, it's hearing, right? Hard of hearing. But the question is asking the best approach that you can use to verify understanding of instructions. And this would actually be the same for anybody, even if they didn't have a hearing issue. So presbycusis, you're thinking this older adult client can't hear, right? He's hard of hearing. So swish this around your mouth. If somebody can't hear well, does repeating it change it? Does it change the fact that they can't hear you well? Will they all of a sudden hear you on the second time or the third time? No, right? So that's not helpful. Demonstrate the procedure. Well, you could demonstrate to someone that has a hard time hearing you. That way they can see it visually. But the question says the best approach to verify understanding. So just because you demonstrate to the client doesn't mean that they understand it. How did you verify they understood it just by your demonstration? So we got to get rid of that. Pour the medication at the bedside. Well, that does nothing to address the fact that they can verify instructions, right? You didn't even tell them what's going on, so we have to get rid of that. So now we're left with D, right? But let's look at that. Say, please tell me how you will do this. And this is the best way to verify instructions in any situation, because you're asking them to repeat what it was that you told them. That way you can verify, did they understand it correctly or did they not understand it correctly? So by saying, please tell me how you will do this, you're able to assess if that patient has the right information or not. Okay? So I hope these questions and this little brief kind of review on the eye issues have been helpful to you.